the peak T wave and the shortened QT interval, not prolonged QT interval, opposite to hypokalemia. Sometimes there is a segment depression, and then usually the ECG changes can occur whenever the potassium level is 5.5 to 6 milliequivalent per liter. However, there is no clear correlation between the ECG changes and hyperkalemia. In another word, that you might have hyperkalemia without any ECG changes. So this is just a cartoon representative of different type of hyperkalemia. The normal value 3.5 to 5.5, which is a normokalemic. This is at the resting potential of cardiac muscle changes. So there is no changes during the normal serum level, except that the normal ECG you see with the P-QRS complex, ST segment, and T-wave changes. They are the normal variation. However, once the potassium reach 5.5 to exceeding around 6 or 6.5, then we will start having the ECG changes in the form of high, very big tinted T wave. And then that's the changes occur in the early depolarization part, which is the ST segment and the T wave. Subsequently, that we will have the serum potassium higher than that level, which is really a moderate to severe hyperkalemia. You will have the prolonged QT PR interval, the depression of the ST segment, and then there will be a generalized slow of the function of the myocardial cell. So the myocardial cell will be slow down. Hyperkalemia is associated with the paralysis of the atrium. So when the atrium is paralyzed, that you might have a prolonged PR interval, or you might have an abnormal P or even absence of P wave. The worst scenario for hyperkalemia is in the ECG changes is that you will have the sine wave appearance, as you can see in the extreme right cartoon changes, that you will have this type of changes, which will end up with either asystole, the patient will have no cardiac activity, or it will end up with ventricular tachycardia and ventricular fibrillation, where the patient most of the time will be arrested. This is an example of the ECG where you can see that the PR interval is prolonged, the peaked tinted T wave in the depolarization segments, which is classical of the usual hyperkalemia. And then you might have this type of hyperkalemia where there is a severe bradycardia with ST segment depression, prolonged PR interval, or absence of the PR interval. And this is, if it continues, it might end up with asystole. As I have said earlier, that the worst scenario for the potassium level whenever it is elevated above the desirable level is the same Q wave appearance, which you can see in this ECG, which might end up with asystole or ventricular tachycardia, ventricular fibrillation, which is the worst scenario. Hopefully will not happen for our patient in the presence of new medication to control this potassium level. So potassium is hyperkalemia is responsible for significant morbidity and mortality. It is primarily due to the impact of elevated potassium on the cardiac conduction. As I have said, that the cardiac conduction can end up with asystole or ventricular tachycardia, ventricular fibrillation, or absence of P wave with just junctional rhythm. There is a significant number of patients with hyperkalemia. They might die, particularly for the dialysis. Almost 0.7% of dialysis patients, they died with hyperkalemia, and up to 5% of the patient with those might die with the end-stage renal failure patients. So it is very important that it is really one of the cause of the mortality. It can reach up to 41% mortality from the hyperkalemia. And this is, you can see that the more you have hyperkalemia, whatever the condition you have, for example, if you have a renal impairment, or you have diabetes, you have heart failure. But if you have a combination of chronic kidney disease, diabetes, and heart failure, then you have significant mortality changes by the presence of hyperkalemia. So it is very serious issue once you have the combination of diabetic nephropathy and chronic kidney disease, as well as heart failure. And this is really a very common limitation of ACE or ARB introduction, which is a very important drug in order to have the optimizing the treatment of heart failure with the chronic kidney disease. But you cannot if the hyperkalemia is an issue. This is clear from UK that hyperkalemia has a significant mortality whenever there's potassium elevated, particularly once it reaches more than 5.5. And then here that the odd ratio for the hyperkalemia with chronic kidney disease, if you have severe hyperkalemia, it can reach up to 20% mortality. And with chronic kidney disease of stage 4, that you may have up to 12% mortality whenever the potassium exceeding 6 milli equivalent. So it is a very serious issue where the chronic kidney disease patient with hyperkalemia may have 10-folds in causing the patient to have mortality. So this is an important slide showing that according to the National Heart Failure Foundation of Adult, that potassium 5.5, you might have a significant mortality reaching up to 5%. So the issue of mortality is important, but the recurrent visit to emergency room might reach up to 50%, particularly if there is one episode of hyperkalemia. The recurrent of the hyperkalemia within 1 year might reach up to 50%. So the revisiting to the emergency room with hyperkalemia for anyone of the patient who developed hyperkalemia at any stage of his treatment is an important burden for the hospital accommodation of these patients. The importance of the hyperkalemia that it interacts between the heart and the kidneys. If the heart is failing, then the kidney is failing, then in the presence of the RAAS, we are going to have a significant hyperkalemia. So this cycle, as you can see, we need to break this cycle at any stage in order to avoid significant hyperkalemia and subsequent mortality. So one should be consider that we know heart failure has different type of heart failure. It is not the area to talk about the type of heart failure, but whenever the heart is not able to pump, then that's a heart failure, and then that will trigger this virtuous cycle between the RAAS system and the glomerular filtration rate and the kidney, and subsequently the hyperkalemia will issue. This is important that hyperkalemia, we have to stop it at two different stage by angiotensin receptor blocker or by the RAAS system. We can block it by angiotensin receptor blocker or angiotensin converting enzyme inhibitor, or a mineralocorticosteroid like spironolactone, in order to have the importance of the vasculature and to reduce the mortality, including the new medication for heart failure, which is the ARNI substances, which is very important in reducing the mortality even on top of ACE or R, on top of the usual medication and usual treatment. So it is important to take in consideration this issue, and then to keep in mind that the hyperkalemia might be the reasons behind the mortality of this patient. So in short, a question will be why we need to fight hyperkalemia. We need to fight hyperkalemia in order to be able to reduce mortality of our patient, not because of hyperkalemia, but to reduce the mortality by maximizing the treatment of heart failure. The treatment of heart failure, whether ACE or ARBs or ARNI or MRA or beta blocker, they are all important to reduce mortality of heart failure. And these drugs cannot be utilized in optimum dosage, as the clinical trial dictate that you go for the maximum tolerated dose. You will never be able to use them on maximum tolerated dose. So what is the options available to us nowadays that to overcome the potassium elevation in the presence of this important medication? We either will stop the drug, or will reduce the drug, or we will accept hyperkalemia, and both of them has a consequences in mortality. This is the last slides for me. I want to show you that the practice to reduce RAAS is not good, because you are going to not to reach the optimum medication or the optimum dose. Subsequently, if you stop the RAAS inhibitors, again, you are not able to benefit from the drugs ameliorating the heart failure and prolonging life in our patient with heart failure. And of course, we are having the choice of reducing the potassium in the diet, but reducing the potassium in the diet is very troublesome for the patient and very difficult to control. Adding diuretics has its own side effect and consequences. Particularly, it is ineffective whenever the renal function is not working well. And of course, polypharmacy is a choice to replace the very important drug RAAS inhibitor by hydralazine and nitrate, which is really an alternative, but it is not a good alternative because you cannot raise the doses of hydralazine and nitrate in patients with heart failure. As you know, patients with heart failure, most of the time their blood pressure is low. Another important area is that probably the resistant hypertension. Whenever we have a resistant hypertension, we need to add spironolactone, which is a very important drug to reduce the blood pressure. But in this situation of kidney disease, situation of significant heart failure, whatever the cause, it will not be, you will never be able to use it. So by this, I will conclude. Then Professor Mitaj will continue explaining the role of ACE and ARBs in the presence of hyperkalemia. Thank you very much.
Thank you, Professor Mustafa, for your nice talk. We have really very useful information for us. We'll keep the question to the end of the talks. And now Professor Mitaj will talk about optimal RAAS dilemma and the new potassium binder for chronic management of hyperkalemia. Professor Mitaj, please.
So I needed to unmute myself. So thanks for the introduction and for setting the stage with this excellent hyperkalemia talk. Happy to be with you and to share some of information from literature, but also my personal experience binding drugs. The first time I was exposed to that is more than a decade ago, because I was also part of the team that was in early studies with Patiromer. So my disclosures to this talk, yeah. Now, as the first speaker has very elegantly presented the how deadly hyperkalemia is, the next question should be, how common is it in our clinical practice? You can see that the prevalence increases from the healthy people to most diseased people, and in I'm a specialist for heart failure. It can be present in up to one half of the patients in my clinic. But what is also important along with that, if you have a patient that experiences hyperkalemia, then the second event will follow in more patients, and the time interval between the hyperkalemia events is getting shorter and shorter. So once you have a patient with hyperkalemia, then this will be a rolling problem. Now, we also know that if we are talking about cardiovascular continuum, we are all along the cardiovascular continuum exposed to the drugs that have the intrinsic risk of hyperkalemia. Here is the an example of heart failure. You see that the RAAS blockers are indicated with the highest level of evidence and recommendation. And basically, we are always trying to navigate between the harmful effects and the benefits along the heart failure trajectory, also throughout the cardiovascular continuum. Now, the clinical trials are the most controlled clinical environment, and here are the trials with RAASi inhibition, not only in heart failure, but in a more wider range of disease. And here is the all of these trials showed the clear benefit of the tested drug on the outcome of patients, but they were also linked with increased risk of hyperkalemia. This is the fact. This also happens in clinical trials, and we cannot evade this risk of hyperkalemia. Now, hyperkalemia is something that, if present, then it interferes with our clinical decisions. So it is the most common reason for not starting the drugs that could be associated with hyperkalemia, and it's also by far the most common reason for the discontinuation of this therapy. So this is something that we are usually doing in clinical practice. Here is another example, how we manage our MRA use. This is in patients with heart failure, depending on the potassium level and the renal function. So above 6, whatever the renal function, we usually stop in all the patients. And in about half of the patients, lower proportion, obviously, in patients with, for that age, almost preserved kidney function. And in more than half the patients with CKD stage 3 or worse, we also discontinue the use of MRAs, and we know that these are one of the cornerstones for heart failure in particular. Now, what is also important for you as clinicians is, and this goes for all the drugs in heart failure, and we're talking today more about ACE inhibitors, ARBs, and MRAs. So the longer the break between that the patient is on the drug and then you again start the patient on the drug, the longer the break, the lesser the chance that the patient will be on the long-term therapy. So the message is, if you have a patient that there is a reason that you need to modify the therapy, then you need to consider starting this therapy as soon as possible. This gives your patient then the higher likelihood that he will stay on the long-term therapy. Now, I was talking about clinical trials, but okay, you may challenge me with the question, what happens in clinical practice? Here is one example. There are plenty. This is the European registry I was also involved with. And here you have the proportion of patients with heart failure that were receiving MRAs. Like 2/3 were on MRAs, 1/3 not. And were not on MRAs. There were a couple of reasons, either that the drug was contraindicated or not tolerated, but hyperkalemia is a major player in this respect. Okay, now, having a patient on the drug is important, but what is also important that you try to reach the target dose, the dose that was used in the trial. Obviously, that's not possible in all of the patients, so we aim usually for the maximal tolerated dose. But again, if the patients were not at the target, and you see that most of the patients were not at the target for the MRAs, again, hyperkalemia is one of the major reasons, because this reason still in up titration. Okay, you may believe it, you may not believe it, but hyperkalemia, again, a major player in non-optimal therapy for our patients, in this case for the heart failure patients. Does this have any clinical implications if you don't treat your patients with the target dose of the indicated drugs? Indeed, it has, and here you again have the variety of patients, but the message is completely the same. So the red bars, and that is the mortality, instance of mortality. Red bars, patients are on maximal dose. Okay, some of the patients obviously die during the observation period, but if your patient is on sub-maximal dose or the drug was discontinued, then the mortality doubles. And this is the message for all of the conditions. So RAAS is helpful in your clinical practice, definitely. There is no doubt about it. Here is a more recent study. We also contributed to these patients, and this was the BIOSTAT study. So we needed to enroll the patients with the potential to up-titrate the titration. So the patients were on less than 50% of the RAASi and beta blocker inhibition, and we pushed for the titration. And then we analyzed the patients in 3 different groups. So the blue line are the patients that are on recommended ACE ARB dose. Then the patients, the violet patients that are on less than recommended, and the patients less than recommended, but also some clinical events or side effects. You can easily see that the survival is clearly different. So the survival was the best if you could treat your patients with the maximum dose. Now, having said that, I believe we all know that the drugs RAAS inhibition is indicated in our patients, but are there any challenges in year 2020? And I've selected, there are a couple that I've selected to talk a bit on SGLT and about the coronavirus. Now, you all know that last year in Paris at ESC HF was presented. This was really a huge study with very, very clear benefit of dapagliflozin versus placebo on top of everything in heart failure, and the result was the same for the diabetic population and non-diabetic population. But in respect to the today's talk, what is important, you need to appreciate, as I said previously, that was on top of everything that is available today. You can easily notice that most of the patients, like 94%, were on some inhibition of RAAS system, and MRAs were prescribed to 70% of patients. And many patients, very many actually for MRAs, were treated with at least 50% of target dose. So well-treated population, you really need to aim for the treatment with RAASi at the highest dose. This is the way, and then you can say that with the addition of dapagliflozin, you can change the outcome of the patients. What we don't know, if you don't have the patients at these drugs and at least 50% target dose, if the dapagliflozin is effective or not, we don't know that at this point in time. But the second thing I'd like to mention, that heavily is present now throughout the world, the pandemic of COVID-19. Here is a figure from a recent paper in New England. We know that the virus utilizes ACE2 as the receptor to enter the cell and to destroy the cell. And there was a hypothesis saying that if you have diabetes or hypertension, then we know that there is the upregulation of ACE2 receptor. And also, if you are treating a patient with ACE inhibitors or RAAS inhibition, then there is also upregulation of ACE2. So the hypothesis was that in these patients, they would have higher susceptibility to infection with SARS-CoV-2 and to worse course of the disease. So this was the hypothesis. Now, I believe this was very clearly refuted as far as we know today with these 3 papers that were recently published in New England, looking into the risk of COVID, these 2 papers, and the mortality. There is no signal for that, and virtually this is well in line with the message that was given, that was shared by many professional societies throughout the world, that we should not stop RAASi inhibition in patients at risk of COVID-19 or infected patients, because there is no evidence for that. Now, in clinical practice, obviously, even today or even more today, we are frequently challenged with this dilemma. So what to do if the patient has an indication for RAAS inhibition, and there is also the risk of hyperkalemia. So we need to aim for cardiorenal protection, and we need to be aware of this second part of the risk of hyperkalemia. Now, the previous speaker also very elegantly discussed the possibilities, what to do. We all know that nobody would like to pay attention to the healthy lifestyle, including the diet, that we usually do that, which is obviously wrong. Diuretics are an option, but very infrequently used, and until recently we only had SPS for the management of hyperkalemia. Now, what about if we try to switch gears and to think like we sometimes think in cardiology, but even more commonly, our colleagues, for instance, in oncology, think that we use one drug to facilitate the use of the other drug or to prevent side effects of this particular drug. Now, this is a concept that is very well known. Here is an example from cardiology. If you have anticoagulant drugs and you add PPI, then you see less bleeding. This is the clear fact. We know that and there is another example from heart failure or cardiology. These are antiemetics and morphine use in flash pulmonary edema, for instance. But there are more. So maybe also for this particular aspect of RAASi inhibition, risk of hyperkalemia, we need to start thinking in this way. And actually, this is also the recommendation. A group of experts recently published a paper in the Journal of Cardiovascular Pharmacotherapy about hyperkalemia. Here are various clinical scenarios you could be exposed in clinical practice, and you can appreciate that the potassium lowering agent is mentioned in 5 out of 6 scenarios. So this is a viable option. So what do we have at hand in 2020? So obviously we still have SPS, yes, but there are 2 new kits on the block. One is Patiromer, the other one is sodium zirconium cyclosilicate, and these are 2 new potassium binding drugs that bind potassium in your gut, and then the potassium is excreted with feces. Now there are a couple of differences between these 2 drugs. They are both approved in the US and in European Union, and also in Saudi Arabia. Patiromer is now about to be launched. It's, as far as I know, is available. As I said, some differences. This drug has a more faster onset of action, I'm sorry, but there could be some more safety tolerability issues, in particular with regards to edema. This can be quite relevant in heart failure patients, in which setting both of these drugs were also tested. Now, what we know until now are the positive effects. We know that both of these drugs can normalize and maintain potassium level. They can reduce aldosterone level, which may be important for hypertension, which is like 10 times more common than heart failure, or at least 8 times. That there are some side effects. This edema, again, mentioned for ZS9. Obviously, this can lead also to disbalance in electrolytes, but there are also some known unknowns. And this in particular goes for the heart outcomes. So whether this normalization of potassium and maintaining of normal potassium level that would allow then for RAASi inhibition can translate to the mortality benefit. This is something we don't know, but I'll offer you an answer at the end of my talk. Now, the rest of my talk will be mostly about Patiromer. These are the uniform shaped particles that are available in the powder form that is dissolved in the water, and the mechanism of action is binding of potassium in the gut, and then you excrete that with feces. So the drug is non-absorbed, it's excreted, it's ingested as a powder dissolved in the glass of water. Now, the Patiromer is not anymore very new drug. So it is the clinical trials have been started in year 2008, and I had the pleasure to join the team in this clinical trial, but I was also consulted previously. So I'm very happy that I had the experience already at that time, and I was very positive about the drug, also about the availability, and now we are actually having the drug for the clinical practice in most of the countries around the world. Now, I would like to walk you through a couple of trials in this respect, and the first one I would like to mention is the pivotal trial that actually demonstrated what the drug is doing. Now, how this trial was conducted, it included patients with CKD stage 3 or 4 with hyperkalemia when using RAASi. So this is these are the population characteristics, and the patients were then stratified, could enter the study either with mild hyperkalemia or moderate to severe hyperkalemia, and they were then randomized to either to placebo or to Patiromer. And depending on the level of hyperkalemia, the starting dose of Patiromer was different. Now, what the drug did, here are the results over the time. It was the 4-week study. So the patients were hyperkalemic at the baseline, and then at already at day 3, the patients were had lower potassium, and by 1 week, the average level was in the range of normokalemia, and this was maintained throughout the study period. This reduction in potassium for patients with mild hyperkalemia was 0.6 millimoles, and for the moderate severe it was 1.2 millimoles, and this is something that you would all agree with me, I hope, that is meaningful for your clinical practice. Now, what is also important is if the patients were normalized with respect to their potassium level, what happened with RAASi therapy. So you can immediately see the huge difference between the proportion of patients that were in need for reduction of RAASi because of hyperkalemia. This is 11-fold or 9-fold difference. And also proportion of patients on RAASi therapy at the end of week 8, you see the clear difference, 50% difference. So this is something that is very much important for your clinical practice. The second study I would like to talk about is the AMETHYST study with inclusion criteria, patients with CKD, type 2 diabetes, hypertension, on RAASi therapy, and some additional requests in terms of kidney damage. Patients who could enter the study with normal potassium level or with hyperkalemia, and the patients were divided in 3 cohorts. Again, they could enter the study with mild hyperkalemia or moderate hyperkalemia. So in 3 cohorts that challenged the patients to get them into the hyperkalemia, and then the patients were randomized for the treatment phase that is mimicking then the previous study. But what is addition, and this is very important, is the maintenance phase. So the whole study lasted for 1 year. Now, with primary objective to see how the patients were, how the potassium was managed. And we know from the previous study that drug is effective in reducing the potassium level. So this is the reduction by week 4 that we know from the first study. And then the potassium was maintained for the whole study period until week 52. And then the Patiromer was discontinued. Obviously, it was expected. The increase in potassium was observed. So drug was effective for reduction of potassium, maintaining the level of potassium, and when Patiromer was withdrawn, the patients again experienced the increase in potassium levels. Now, going to the population that is in need of RAASi inhibition, these are the heart failure patients. This was the first study, PEARL-HF. This is the study design. So the patients, I'm sorry for that. So the patients with chronic heart failure with indication to receive spironolactone and potassium at, we would say, normal range with chronic kidney disease and on RAASi inhibition, but with the addition of documented hyperkalemia that led to discontinuation of RAASi beta blocker within 6 months. Now, the patients were randomized to placebo plus spironolactone or Patiromer plus spironolactone. Patiromer was in the fixed dose, and then spironolactone was up titrated depending on the potassium level, or maintained or discontinued. And this was also the 4-week study, and these are the results. So the patient started off with the similar potassium level, but then you clearly can see that the curves diverged. This was the Patiromer, this was placebo, and at the end of the study, the difference in millimoles was 0.5 millimoles, which is clinically important, obviously. What was also important, more patients in Patiromer group were able to do the up-titration of spironolactone, and also the incidence of hyperkalemia was 3.5 times less frequent in Patiromer group, so 7% versus 25%. Now, the second study I really like to include in my presentations because all of the previous studies were blinded. Now, in clinical practice, we are not blinded. We see the patient, we know what we are doing, we know which parameters we need to follow. And this study actually mimicked your clinical practice. These were the heart failure patients with chronic kidney disease, with a baseline potassium in normal range. Also, GFR was in the CKD3, stage 3 range or worse. And then we did the open label study. So how did this study go? Patients received spironolactone plus Patiromer. And then we, in open label, adjusted Patiromer, and we tried to uptitrate spironolactone to 50 milligrams. Now, how did the study go? This is the potassium. And by day 7 or 14, the spironolactone was uptitrated. We were able to uptitrate to 50 in all patients by day 14. You can see that the mean potassium level was always in the normocalemic range, and we adjusted then the Patiromer level to keep it. Here are the proportions of patients in what we usually have in our lab reports, which is the normal potassium level, and these proportions of patients were always higher than 90%. If we are a bit more strict, then and we say, okay, we want to have the potassium between 4 and 5.1, then at least 70% at any time point throughout the study were in this range. Now, if we try to switch gears a bit from heart failure to hypertension, which is more common than heart failure, and we also know that resistant hypertension is something we need to pay attention to, and we usually go for spironolactone. This is also in the recent guidelines, being that from Europe or from the US, that the drug of choice, we were not successful, then it's spironolactone. But we know that spironolactone is associated with hyperkalemia, so this study is very important in this respect. So these are the baseline characteristics: CKD in 100%, heart failure almost half, type 2 diabetes 50%, and all the patients on RAASi inhibition. So patients with resistant hypertension, with what we usually refer to as normocalemiia, were randomized to spironolactone and Patiromer, or spironolactone and placebo, with open additional antihypertensive medication is needed, with primary endpoint difference between treatment groups in proportion of patients remaining on spironolactone at week 12. Now, here are the results. More patients in Patiromer group were able to keep the spironolactone on board, and the difference was 20%. This is clearly statistically significant, but also clinically significant, obviously. Here is also the couple markers for time to discontinuation of spironolactone. And what is also important is this. So the incidence of hyperkalemia, if you were treating the patients receiving spironolactone with placebo, 2 out of 3 developed hyperkalemia. So the curves diverged very early and they stay apart. So this is like 40% difference in incidence of hyperkalemia. So what does this mean then? If we try to summarize the information from the trials, obviously the drug is effective in reduction of potassium level, but it is also effective, this is important for this talk, in enablement of RAASi therapy. Here is the OPAL example, 50% difference. Here is PEARL-HF, 17% difference. Here is AMBER, 20% difference. All statistically significant, but all also clinically significant and meaningful. Okay, nothing comes free in life, so we also need to pay attention to safety, tolerability. There are some tolerability issues. There are very few safety issues. So what is usually asked, what is the risk of hypokalemia? Yes, there is the risk of hypokalemia. Obviously, patients need to be educated, but you also need to monitor potassium, but we all do that in our clinical practice. There is some risk of hypomagnesemia, which is usually mild to moderate. We, at least in our heart failure clinic, we always also look for magnesium levels. there is some there are some interactions where, and also in the drug instructions there is the instruction that you should ingest Patiromer at least 3 hours apart of other oral medication. Now, presenting you the information that we have available until now, there is also the development in the documents, being that the guidelines or expert consensus document clinical update, either from the ESC or the heart failure, that, and this is important now, that in selected patients, Patiromer and ZS9 may enable use of MRAs and other RAASis in more patients and at higher dose. But this is the known unknown, as I already alluded to you previously, that we don't know whether this will improve patient outcome. So this is the missing information as we have it today. Now, what the other question people usually ask, okay, these are the clinical trials, but is this applicable to my patients? So at least for that open label study, you could say yes, but if we take a closer look at the population in Patiromer trials, then this is what we usually see in our clinic. Now, almost 100% RAASi, half heart failure, 60% elderly patients. So this is our usual clinical practice. Also, hyperkalemia very often present and at the levels we usually see in clinical practice. So trials using Patiromer, very close to clinical practice. But also, I would like to share with you one observational cohort that was recently published in PLOS One that looked into the practice of Patiromer use, SPS use in the US, and also what would be effect on the heart resources use. So these were this was, as I said, retrospective observational that compared pre-post of the index date heart resources use, but also described the patterns of Patiromer and SPS use in the clinical practice. So these are this is the first important result I would like to share with you. If the patients were put on Patiromer or SPS, then patients on SPS rapidly were discontinued from the drug. So by day 30, 10% were on the drug. This is not the case for Patiromer. At day 30, 70% were on the drug. And more patients stayed on Patiromer throughout the follow-up. So this is the first important message for the drug that is now entering the clinical arena, and the drug we know for ages. The second information, which is important from this study. So if you had your patients on Patiromer, those were the patients with hyperkalemia, then those patients were more likely to stay on RAASi therapy. So you see at these were the two populations different, but all the figures are higher for Patiromer than for SPS or no potassium binding agent. The third information I'd like to show to you, this is now relevant for clinical practice. This is the hospital admissions and emergency department visits. You see that the bars for Patiromer are always showing the reduction. For SPS, also hospital admissions, but for no potassium binding drugs, obviously increase. So the Patiromer definitely had the highest, should we say, savings for the healthcare system, but also benefit for the patients in terms of hospital admissions and hospitalizations. Now, if we take a look into the future, I believe that the message is clear that hyperkalemia is an issue, that we need to tackle it. Sometimes we don't have in recent years we didn't have the good strategies, but now we have. So we need to do it, but we also need to look into the future for the missing information. I would like to share with you two studies that are ongoing. First one is with ZS9 with primary endpoint that is not going to tell us the most important answer. So it will look into the treatment strategies on proportion of patients being on RAASi therapy will be the randomized trial in heart failure patients comparing placebo and ZS9 with these primary endpoints. But the real game changer is the Diamond study. So this will be the study also in HFrEF patients with CKD stage 3 or worse, with high potassium level, and these patients will be then randomized to placebo Patiromer with the primary endpoint of a combination of cardiovascular death, cardiovascular hospitalization. So the heart endpoint, really telling us whether this enablement translates into the mortality benefit. So this is the missing link, and the trial is ongoing. The patients are being recruited as we speak, and we will still need to wait a couple of years, I believe, to at least 2 years to see whether this is effective or not. Now, my final 2 or 3 slides. A patient from our clinic. So as we do the patients in our heart failure clinic, this is the male patient, 67 years, with ischemic heart disease that affected his left ventricle, which is dilated, poorly contractile. So with clear indication for RAASi inhibition, also for the other device therapies. So what we always do in our heart failure clinic, we always do the ECG, obviously, we always do the blood pressure, we always do the, we weight the patients, we do the lab, but what we also do, we always do, we usually with V-scan or the any device you have, we do the volume assessment in our patients with B-lines, the lung ultrasound, and inferior vena cava to pay particular attention to diuretic therapy and also to other therapies that could affect renal function in particular, and then the volume status. So this is what we do, and at this stage I missed one. Yeah, I missed one. Sorry, I skipped one slide. So at this stage, we decided to add eplerenone to other therapies, and then the patient came back usually in 2 weeks. If we estimate that the patient is the high risk, then we take the next visit at 1 week. And obviously, with eplerenone, the patient developed hyperkalemia, the renal function went down. So we asked ourselves what to do. And obviously, some of the options are better than the others. Maybe this option is something you could do, as we did. We added Veltassa to this patient, and in 1 week time, the patient was again with us with the normalized potassium level. But the important question for clinical practice is, this also goes then into the direction of risk of hypokalemia, and to see when the patient will be needed to be seen to check for his renal function and potassium. This is the question for your clinical practice. And if you have the patient on Patiromer, we know that the onset of action, the normalization of potassium is slower than with ZS9, but this is a particularly useful algorithm that could be implied also in your clinical practice. If you have the patient that you start on Patiromer, then if you have the possibility, you should measure the potassium for the first time at 2 or 3 days, and then repeat at week 1. Because this was done in the same way in the trial, but I would understand if you don't have this possibility, then at least at week 1 you should do it, and then depending on the potassium level, you decide whether to maintain if the potassium is normalized, and then measure at 1 month, or if the potassium is still elevated, you need to up-titrate the dose with the target of potassium to be lower than 5. Now, if I may summarize my talk, so I would put it this way. So hyperkalemia is one of the principal reasons for reducing or stopping the RAASi therapy. This clearly is affecting the outcome of the patients, because we know the submaximal dosing discontinuation will definitely worsen their outcome. So there is the unmet need for an effective long-term treatment for hyperkalemia that would enable the RAASi therapy, at least the RAASi therapy, but also to facilitate the target doses. And as I believe I have demonstrated sufficiently, Patiromer has demonstrated efficacy and safety, not only in heart failure, but also in other clinical scenarios, including hypertension, resistant hypertension in this respect, and maybe a solution to maintain patients on a guideline-recommended RAASi dose and potentially to improve the outcome. And this is the missing part of the information, but it's being tested in the ongoing Diamond trial. So that's it from my side. I hope it was useful. I hope it was also clinically relevant, and I do wish you all the best with Patiromer use in your country. Thank you.
Thank you very much, Professor. Actually, we have joined your talks, and there are many new points we learned today. I appreciate your time and your help us about the management of patients with heart failure and kidney dysfunction. Now we have the final talk from tonight. Our colleague from the university, Dr. Fakhr Al-Ayoubi, she will address the current treatment option for acute hyperkalemia management come with limitation for long-term use. Dr. Fakhr, please.
Assalamu alaikum wa rahmatullah. Good evening, everybody. Thank you very much, dear professors, for the very informative information that together. As you said, hyperkalemia is an issue. It's a problem. And we are here to discuss about how to tackle it. And also, it's not just how to tackle it only, also how we can manage in the long-term management of the patients. That's why I think we are here today. We're trying to cover the impact of hyperkalemia, as we all covered today, in different chronic disease. Also, what do we mean by hyperkalemia, the acute and the chronic? What we talk about the old medications and the future medication. The other thing is that we have limitations for the long-term use. Still need data about that, but we can start. And of course, the role of pharmacists and the pharmacoeconomic part, that is very important for our practice. Now we can see here we have a patient who is in the heart failure clinic. And as we can see that the side effects of the medications that we're telling our patients to be on by itself is causing hyperkalemia. We tell the patient, take the medication, you have to adhere to it, but we developed hyperkalemia after a while. So this is why we are here today. We are here to tell the patients, you have to adhere to medication to decrease your hospitalization. But if the patient takes all these medications, for sure he will develop hyperkalemia. So this is what we are concerned about. Let's say that hyperkalemia is not an easy task. It causes malignant arrhythmia, and it is appearing in different chronic disease, as you could see. The acute and the chronic all are important and highly concerned to manage. The most important thing is that sometimes to treat it, we have to discontinue a very major drugs that are very important to improve the patient's outcome. And the other thing that in cardiology field where we are practicing, we always tell the patients that the normal potassium level should be within 4. So now every time I know it's different from one department to the other, from one specialty to the other, but 4 actually is our golden target. Most of our patients really have to go within this level. As you can see, there's a summary here about medication themselves that are causing hyperkalemia by giving them to the patient. This is a very nice summary telling us that the ACE, the ARBs, also the mineralocorticosteroids medications, the potassium-sparing diuretics, the non-steroidals, digoxin. All of these drugs, if you give them each one of them or together, they will develop this problem. So we might have something called acute, but our concern today, I think, mainly would be about the chronic type, because it's difficult to cover both treatment in one lecture. And the most important thing in hyperkalemia is how to make it go down and not to go to hypokalemia. This is the beauty about this potassium binding medication. The traditional way, it is summarized in this table to treat hyperkalemia. We used to give calcium. I will talk about each one in details, but look at the duration here. The onset of action is supposed to be very quick. That's why we call them, they are the treatment of acute hyperkalemia. And it is to be discussed, of course, because each one of them has its own limitation. And you cannot give them for chronic disease patients because it will just treat it for now, but this not will be the solution. The other thing is that you can see the most time consumed here is with the sodium polyesterase sulfonate, which is again the old way of treating hyperkalemia. The point that I would really like to focus on is that once you have hyperkalemia, you need, as Dr. Mustafa told us, we need first of all to divide which stage my patient is in, set a plan for treatment, and of course, decide how to start. If you have a patient who is more than 6.5, you go directly with an acute treatment. What I mean by that, we can start with calcium, for example. There's the calcium gluconate or calcium chloride. But again, these drugs are given just for acute management. They have their side effects, and they are used to stabilize the myocardial membranes. The insulin, again, is one of the traditional way that we used to use, and it's working, of course, on the sodium potassium ATPase channel, which transfer the potassium into the cell. This is where you decrease the potassium. Usually, we give a bolus dose of the short-acting insulin. Again, this is an old way of using the traditional way of treating hyperkalemia, but you have to be careful because patients might develop hypoglycemia, which means I have to give glucose as just a backup for this kind of medication. The other one is the sodium bicarbonate. I know lots of our cardiologists still using it, and we still need it. And as I said, it's not considered the first line of management of hyperkalemia, but we can give a bolus dose of sodium bicarb, 8.5%. This dose is to decrease the potassium to at least a normal level, but it will not maintain this normal level. The other thing is that it will increase the fluid load, which means that if you have a patient who has a problem, respiratory problem, it might cause carbon dioxide toxicity, and this is dangerous for the pulmonology patients who have a problem in their lungs. The beta-2 agonist, again, by inhalation, which can also decrease the potassium level from 0.3 to 0.6 milli equivalent per liter within 30 minutes. It could be, again, given in high doses for hyperkalemia, not the same doses for other indications. Because of that, patients might develop, again, side effects, which is tachycardia. That's why it has to be given with caution, and it's not a monotherapy for acute management. The diuretics, which we were talking about, loop diuretics for normal kidney patients. This is how we use. We give them diuretics within half an hour, 1 hour. Loop diuretics will solve it for you. The other one, which is the one that we were focusing on, and thankfully Prof was talking about it, SBS. It is introduced in 1950, before even the FDA. It has been used extensively to decrease the potassium level. There has been lots of reports, there even a warning report from the FDA telling us that using it with sorbitol might cause necrosis, which is dangerous side effect. So that's why it has to be given with a sorbitol-free enema or powder. The last, of course, solution is the hemodialysis, which is, again, when all the pharmacological treatment fails, you can go to dialysis. This is all the old, or we call them the acute or the traditional treatment. What about the future treatment? Now, 2 agents have been introduced to the market, which is potassium binder, the Patiromer, which is one of them, and sodium zirconium also has been proved to be used in the market. Both of them will work on exchange of potassium. One, which is Patiromer, exchange the potassium with calcium. Sodium zirconium will exchange it with sodium. Now, as thankfully, Prof, you covered most of the information about this drug. It has been introduced in 2015, and it is in the market. It's even approved in the Saudi FDA now. It's in Saudi Arabia. It's not absorbed. It can work within the 48 hours, and it runs into the GI. And the more the pH in the colon helps, the better effect it will give. The beauty part about this drug is that you can see in all these 3, I'm focused on these 3 actually studies because they were talking about patients who are with chronic kidney problems and mild to moderate hyperkalemia, for example, the OPAL study, and they said the endpoint was decreasing the potassium. The thing is that start within the first 24 hours or even 4 weeks, and it maintained it like that, which is what we're looking for. The AMETHYST also did the same thing with diabetic patients and also kidney problems. They achieved the goal of decreasing the potassium level, and the PEARL study also that was covering heart failure patients were normokalemic, but these patients had a history of hyperkalemia because of the heart failure medication, and also again they were able to significantly decrease the potassium level. On the long-term also measurements, the same study, the OPAL study, was telling us that about 4 to 8 weeks group study were able to maintain a normal potassium level, while if you compare it to placebo, they had an increase in the potassium level to 0.7%. The other thing is that also when you compare them together, you can see that the Patiromer group were even able just to maintain the normal level, potassium level. Few of them reported the higher, which is 5.1 milli equivalent per liter potassium level, which tell us that even on the long term, we can use this medication for maintenance in chronic indications. If you compare it now, you can see that there's a favorable actually utilization of Patiromers or potassium binders to the old SPS, which is again, it's exchanging the potassium with calcium rather than sodium. The other thing is that potassium binding with Patiromer is double the one that was in the SPS. The other thing, adverse drug reactions, it's a little bit lesser. You can see hypomagnesemia only 5%, while in the SPS it's much more higher. So it's well tolerated by the patients. And when you use it with sorbitol or not, there's no problem. By the other one, which is the SPS, it has to be sorbitol free. There is a clinical trial supporting the use of these potassium sparing or binders compared to the others in the heart failure in the chronic disease patients, which means that clinically we still have evidence that these drugs proven to be the treatment of hyperkalemia, and with these two agents we can maintain our heart failure or chronic disease patients on the RAAS medications without needing to stop the medication, the RAAS medication, or even decreasing the doses of our medications to reach to the target doses that our patients need according to the guideline. Getting the up titration, the maximum therapeutic dose to the patient, at the same time with less side effects. Now, the point here that we need to focus on is that it is becoming in a powder. It's a sachet. You have to dissolve, tell the patient to dissolve it in water. Patient had to use it within the immediately after dissolving with water. There's food, no effects of the food on it. It has to be given daily on the same time. The other thing is that once it's dissolved, patients should take it, as I said, immediately or within like 1 hour of dissolving the powder. There is a role of pharmacists in this, and this is why I'm here, because pharmacists, first of all, have to screen with us who is at risk of hyperkalemia. Once they are able to do that, they should know about this new treatment. They should assign proper doses and plan management for the patients who need it. They should also assess the drugs that are causing hyperkalemia and the patients who have chronic conditions to be followed at least, let's say, every month, every visit for their potassium level in order to maintain the hyperkalemia once it starts. The safety and efficacy of this agent has to be also monitored. They should counsel the patients about the hyperkalemia and also tell them the adherence to their medication. They should also involve the dietitians in order to control the potassium in the patient's food. And of course, the follow-up of the response of the patients and the labs. Because as you can see, all the studies told us that we can start the medication, but follow-up is a very major point to follow the outcome of these patients. The other thing is that we need to adhere also to the patients the importance of adherence to their medication. What do I mean by that? You can either write this, sometimes we use manual notes, but using technology now is an excellent way, either by a reminder or by an application. you download it on the patient's mobile, and tell the patients to take those medication on time. You set it in the clinic. You tell them that I want you to come with a monthly report about the missing doses or missing medications that you did not take. So now I'm proving the adherence. I'm following the hyperkalemia. We are doing a great job. And from that point of view, you will decrease the hospitalization, which is the pharmacoeconomic part of this medication. I know the most important thing we face in our hospitals is telling us you have an expensive medication, we will not approve it. But when you look at the cost, which is the direct cost, you really need the time of the physician, the nursing, the pharmacist, the time of the healthcare providers, also the cost of the drug itself. You look at the cost of the bed in the hospitals. If you join that all together with the cost of the medication, I think that would be the proper way of acting toward approving or disapproving any medication. The other thing is that you need to educate the patient. You need to decrease their visits to the hospitals. And this is again by following their lab and their adherence to medications and of course to the instructions. So in final words, absolutely I agree that hyperkalemia is a serious condition, and it appears among lots of heart failure patients and chronic disease patients. The other important thing is that we need to keep our patients on the golden medication, which is the RAAS system. So by controlling the side effects of these medications, and I think a proper control would be the solution for these patients to get the benefit out of these golden medication. The other thing that we need a consensus between the nephrologist, cardiologist, and physicians practitioners in order to see how we can put this kind of potassium binder medication in our new guidelines to treat the heart failure patients, the chronic disease patients, the kidney disease patients, in order to know how to use this medication, when to use it, and make it easy to apply for all practitioners. Finally, I want to tell you that still we need to work more on the long-term use of this medication. And to do that, we first need to start this medication and see the outcome on the patient. And then according to that, we can decide about how long we can use this medication on our patient. Thank you very much.
Thank you very much, Dr. Fakhr, for this very, very informative talk about the current management of hyperkalemia and how we should deal with the patient. Now we will open the floor for discussion, and we have many questions from the floor. So let me start myself asking Professor Mitaj about his real life experience now in this drug, because we haven't yet used it in the kingdom here. How common do you use it in your life patient now, in your experience? How common you use it in heart failure patient, in life measure, and in hypertension as well?
Thank you for this important question. In my clinical practice, we mostly do it in heart failure patients because we run heart failure clinic, and in this heart failure clinic we only include patients after hospitalization. So these are the ones at highest risk for clinical event or hyperkalemia or chronic kidney disease worsening. So these are the ones that really need to be closely followed. So until recently, we just had the possibility to adjust the RAASi therapy now with potassium binding drugs. This has changed, and it is done by individual patient. We decide whether to put it on the drug, because as it was very nicely pointed out by a previous speaker, we also need to educate the patient and everybody who is working with the patient, because we are giving this drug to prevent hyperkalemia or to be able to maintain the RAASi inhibition at the appropriate dose. But with that, we also assume that there will be no change in the RAASi therapy. Because if there is a change in the RAASi therapy, like for instance, RAASi therapy is reduced or abandoned by or withdrawn by, I don't know, by the GP, then the patient needs to know that also the potassium binders need to be adjusted. So what we say to our patients, that they always need to consult us when there is a change in their therapy.
The question, how common do you use it now? Let's say you have in your clinical heart failure clinic, you have, let's say, 100 patients who are on your clinic. How common do you really use it in your life patient management? I want us to know,
Okay.
in our practice, how expect it to be used. Is it 10%, 20%? Because, you know, we have patients in the kingdom here, we have many diabetic, or we have, unfortunately, chronic heart failure is common, as well as renal disease. In your practice, how common do you use it in heart failure and hypertension?
Okay, it depends a bit on the level of potassium. Now we know that in our, at least in our heart failure clinic, hyperkalemia, when we used to get worried, was fine to 5.5, but now with the drug available, it's 5.1, and the proportion of patients that experiences this level of potassium is, shall we say, about 20 to 30%. So these are the candidates for the potassium binding drugs. And if the patient agrees, then the patient receives the drug.
Okay. Now, the question for Dr. Fakhr, what do you think the first treatment for hyperkalemia should be? Dr. Fakhr, do you hear me?
Yeah. Again, and I couldn't.
The first line medication to treat hyperkalemia. What is the first line medication to treat hyperkalemia?
In our heart failure clinics, we start with diuretics, of course. This is the first line of treatment. We go with loop diuretics, especially if you have patients who doesn't have a kidney problem. And we increase sometimes the doses, like for loop diuretics, we go to 40 BID of furosemide. Sometimes even can go to higher doses, like 80 TID. But this is the available, at least, medication also that we have here in Saudi Arabia.
So the first line in our practice now is basically diuretics. What about Professor Mustafa? What do you think the first line should be?
I think in heart failure patient who can't respond to the diuretics, then diuretics has two advantages. The advantage of probably reducing the potassium, particularly if the potassium in the moderate range, or and then it will help us, unloading the heart by reducing the fluid from the system. So I think I will agree with the diuretics in heart failure in particular, but providing that they are responding to the diuretics, because if the kidney function is down below the GFR of 50 or so, then the response will be small and on the expense of a very high dose of diuretics. That's why most of the time we are having not only one diuretics, we are giving the furosemide, we are adding metolazone, sometimes Bioronics. So the diuretics doses might not respond, the patient might not respond to the usual doses of diuretics.
The other treatment is decreasing the RAAS, or even omitting doses of RAAS, and sometimes we switch to hydrolysine and nitrate.
Professor Mitaj, please go ahead.
If I may join the discussion, I would be very cautious with diuretics. I've shown you that what we always do at every outpatient clinic, in every patient, we do the volume assessment with imaging. Because if you over-diurese your patients, then they will be hypovolemic and they will get into acute renal failure. And that will then start hyperkalemia and everything. So with diuretics, volume management is one of the most difficult issues in heart failure patients management. So I would be very cautious with diuretics. So what we usually do, if the patient has the elevated potassium level, we check again for potassium. This is point one, at the same day. The point two, we talk to the patient, we go through the drugs, we look for the potential reasons why the potassium went up, like, I don't know, fever, infection, hypovolemia, diet. We again instruct about the diet, and the very last step is to do something with RAASi inhibition. We then rather see the patient again in 3 days or 1 week, but we just don't want to stop with the RAASi inhibition.
Professor Muhammad, if you allow me, I want to ask you yourself that, most of our patients with heart failure, they are not on in randomized control trial doses. Most of our patients, they are suboptimally dosed. So the dosage of the RAAS system inhibitors is not optimum in most of our patients. I can say that only 40 to 50% in maximum they can tolerate the maximum dose of RAAS inhibitor or MRA. That's why probably we are not we are going for the diuretics at that stage. And I think this is an opportunity for us that we learn that there is a way of getting potassium down with less of side effect and with maximum optimization of the RAAS inhibitors, which is really a new way to go. Maybe by the time we are familiar with this drug, we might not park on diuretics, particularly if the patient has a significant renal impairment.
There's one question here about the alternative to the spironolactone, which is Brianon and hyperkalemia. In your experience and recommendation, we can start with Professor Mitaj about this Brianon.
Okay, so yes, both drugs very useful in patients. Proportion of hyperkalemia from my clinical experience is about the same, but the eplerenone is much better tolerated. So we frequently switch from Spiro to eplerenone, but the incidence of hyperkalemia approximately the same.
Okay, Dr. Mustafa?
Well, eplerenone is not available in our hospital, and I think it is not available in the whole kingdom. That's why what we know is the spironolactone, as the cost is reasonable, and the experience with it, we know it. We don't have, although the randomized control trial and the recommendation that either of them can do the same job.
For Dr. Fakhr, why physician give patient with hyperkalemia a bottle of calcium carbonate powder?
Because you know that it will, they are assuming about the exchange of the calcium with potassium. So they want to have like the acute exchange to decrease the potassium level.
Okay. Any comments from the other members, our staff? No. Okay. Why hypercalcemia mortality more with the CKD stage 3? Why hypercalcemia? They talk about high calcium now, mortality more with the CKD stage 3. Anyone want to take this question, Dr. Mustafa or the Professor?
Well, in my, we know that I don't know whether this is a true statement that hypercalcemia having a higher mortality than hyperkalemia. I will doubt this statement.
Yeah.
However, the new drugs, maybe Dr. Fakhr will comment about it, that it is not causing significant hypercalcemia as well, though it is exchange the potassium with the calcium, but there is no hypercalcemia being reported significantly with the uses of this medication.
Well, yeah, because the nice thing about the Patiromer and the other, anyhow, the potassium binders, they are binding with the extra potassium. So accordingly, there is a limitation for the exchange. I think what they are talking about, Dr. Mustafa, is your slide that you said that in CKD3, the mortality is higher than CKD4 when patients is developing hyperkalemia. Maybe that's a mistake. That's a wrong, maybe, question.
Yeah.
Remember, in your slide, you said that when you...
No, I meant to say that hyperkalemia is the cause of mortality in stage 3 and the stage 4, but probably we missed.
It's good.
Okay.
Our audience are listening to our slide and reading it. That's good.
Now, the question about the D5 water with insulin, hyperkalemia, is this obsolete measurement or new generation medication or Patiromer is widely available? I think they were talking about two different issues here about acute management and chronic management. You cannot compare acute management giving insulin and D5 water with the long-term therapy for such patients. Any comment, Dr. Fakhr?
Yeah, it's a nice question because I say all the treatment, but we should talk about it because I know that most of our audience, I'm sure they practice it. They practice it themselves, the hypokalemia and hyperkalemia. But now these actually are not used unless you have no other choices. It's not the golden way of treating acute hyperkalemia.
Okay, Professor Mitaj, when do you check the level of potassium after you start a new treatment, Patiromer?
Okay, so from the clinical trials, we know that you should do it 48 or 72 hours after you started the drug, you initiated the drug. This would be ideal scenario. If this is not possible, then at least at week 1. But ideally should be 24 to 72 hours, because we know that by that time some effect is evident and you would like to follow this effect.
What do you think, Dr. Fakhr and Dr. Mustafa, is feasible in your practice, in your heart failure clinic, to see patients in such a short interval after 72 hours or say 48 hours, I mean 1 week? Do you think it's really feasible in your clinical practice, Dr. Mustafa?
Well,
and Dr. Fakhr?
first of all, I think most of the time we are observing the hyperkalemia in inpatients, heart failure patients. And probably the uses of medication during this medication during the hospitalization will make it feasible to check the potassium 48 to 72 hours or before discharge. However, if it is in the outpatient clinic, our heart failure is usually, we have a walk-in clinic for heart failure patient, and it could be checked within 72 hours. But in general cardiology clinic, I doubt that it will happen, because if you are going to do that, then you will have a lot of patients coming without appointment, as the appointment for the usual cardiology clinic is exceeding 6 months.
Dr. Fakhr, what do you think in your clinical practice?
This is what I'm telling you, that we need a role of pharmacists to now be stronger, because we need to follow the patients, as we said, in a very soon time. And in heart failure programs, usually we have a walk-in clinic, as Prof. Mustafa said, in order to, after you start the medication, we do the levels. But overall, if you don't have a walk-in clinic, or the patients will not be seen within a short time, I don't think it's easy to start this medication.
You know, nowadays we rely on nurses which are trained for heart failure more than physicians. Actually, we have teams. The teams consist of a physician, clinical pharmacists, trained nurses, and the social worker, and as well. Professor Mitaj, please go ahead.
So yes, I would like to join this. You named a couple of team members. Nurses can be one solution to this part of the issue, but also don't forget the GPs. So if in our clinic we know that we could not see the patient in 2-3 days, then we call the GP or ask the GP to do the potassium check.
Okay. Now, one
well,
question.
the GP,
yes.
Professor Arafa, maybe for their structural healthcare system.
family physician and primary care centers, where the patient is really very well filled out. Hopefully one day we'll have such a system where we can call the GP in the nearby home the patient was living and discuss this issue with him. But hopefully this will be very soon. The question about diet rule here, this question for Dr. Fakhr: should reduction in dietary potassium be recommended in addition to this drug, or does it make any difference?
We should, as Prof. Mitaj was telling us, that before we do anything, we have to educate the patients about the diet control of potassium. And this is actually one of the first line treatment before we start any medication. Now, if we're going to start this medication, the other thing that we still have to restrict the patients from taking some potassium food, because we are trying to control the source of potassium. It will not be as strict as without this medication, but when he's on it, he should be instructed how much potassium he can take through the day. But food does not affect, again, I think this question has two parts: potassium containing food, and the other part is, does food affect the absorption? Because as I said, this drug is not absorbed, so it will not affect the absorption and the effect.
Okay. So in our society, as you know, Dr. Fakhr, dates are very rich in potassium, and our main food actually is especially during these days, we take a lot of dates. And I think in our practice, we can see a really difference where the patient are used to take dates. They might eat 15 ones at one sitting. I mean, this by itself will make the potassium quite high. So I mean, diet is still have a role to to be modified.
And banana and orange. Yeah,
Yeah.
you're right. Yes.
Yeah, definitely. Now, there's one question here is, in case of rhabdomyolysis, any specific management for hyperkalemia? Rhabdomyolysis and hyperkalemia, any specific management? Professor Mitaj and then Dr. Mustafa.
Well, in rhabdomyolysis, you always need to consider the risk of acute renal failure. So many of these patients would end on hemodialysis, which would then also effectively treat any electrolyte disturbance. So if you have such a patient, you definitely need to check for potassium level. That would be my message.
Yeah, but anyhow, the rhabdomyolysis is a very rare condition, and it might occur usually in the setting of coronary or intensive care, and subsequently it can be managed by the intensive care. And I think this is the time probably you might use the sodium, potassium, and insulin, the sodium, potassium, and dextrose to modify the hyperkalemia in that setting. However, the dialysis is most of the time, as I have said, that this patient is an intensive care patient, is not ordinary. And then the rhabdomyolysis, it has a stage. There is severe rhabdomyolysis, and there is mild, moderate rhabdomyolysis where you can manage them with the simple measures.
Dr. Fakhr, any difference between calcium gluconate and calcium carbonate in treatment of hyperkalemia?
That's a nice question. The most practice is with the gluconate. The difference is the amount of elemental calcium that we have in each one of them. The highest is the chloride, calcium chloride. The least is the calcium gluconate.
Okay. Now the question for Professor Mitaj about experience in pediatric population in this new treatment. So do you have any, or what should be used for pediatric age or not?
I don't have any experience, and as far as I know, no trial addressed Patiromer in pediatric population.
Okay. Question again for the group. When should we resort to hemodialysis in CKD patients? I guess for hypopotassium. When do you think potassium is needed to be? This is a question for Dr. Mustafa. When do you think that potassium should go for dialysis?
I think sometime you might utilize all the measures to reduce the potassium, particularly in the acute setting where there is severe hyperkalemia, because severe hyperkalemia might not respond to the usual measures, and subsequently you will go for the dialysis. I think once you are exceeding the severe, like more than 7, then I think the dialysis will be required as soon as possible. Though the initial measures of the emergency take care of those patients by giving them sodium, by giving them dextrose and insulin.
Any comments, Professor Mitaj?
Yes. When you have hyperkalemia, you need to know what is the reason, and you need to remove potassium from your body. And the only 2 ways of removing, because all the other measures are only shifting the potassium from extracellular to intracellular space. So the only 2 ways to remove potassium are either via kidney or via gut. So in the end, you need to remove potassium through these 2 ways, or to do hemodialysis.
Yes, but once it is once the patient in the acute setting of significant hyperkalemia, whatever the drug you are going to use, it will require time. For example, if we will use these binders, you need 3 days to have the effect, and subsequently it might not be feasible. So probably the dialysis and plus minus this shifting technique of getting the potassium lower.
Yes, definitely. So the shifting is the fastest.
Yeah.
And calcium is used to stabilize the membrane because of the risk of arrhythmia. And then you try to shift the potassium into the cells, and then to buy time to remove it from the body. So this is the strategy in the acute setting.
Professor Mitaj, the most red flag side effect that drug stopping, urge drug stopping, Patiromer, we should give magnesium supplement for the start, or as the drug causes hypomagnesia, or what is the level we should give magnesium supplements?
Okay, this depends on the patient and how the patient looks like, whether there is an increased risk of arrhythmia. We're afraid with hypomagnesemia, but usually if the patient on Patiromer experiences low magnesium level, this is mild hypomagnesemia. In many patients, we just add magnesium to their regular diet, so to speak, not to medication, but to diet, because we very rarely see problems with high magnesium level.
Okay.
So in many patients, we just do it from the very start of the treatment.
Okay. Dr. Fakhr, they're asking here about the difference between calcium resonium and sodium resonium in treatment of hyperkalemia.
All of them are binders. Resonium, it means it binds the extra amount, and it's just actually either excretion through the urine or the feces. The difference is just the salt, but the mechanism, it's the same. The other thing is that, as you could see in the binders, they don't touch the sodium part, so they will not develop hyponatremia, which is a common side effect of diuretics. So to the extra amount, and sometimes even it's binding to extra amount, but it's just a matter of the salt that's inside.
Okay. Professor Mitaj, any role of Patiromer in acute hyperkalemia?
Well, it can be used. It depends a bit on the level of potassium. It's not the first drug to treat acute hyperkalemia. If you compare this with ZS9, the ZS9 has the faster onset of action. But as we said, if you have a hyperkalemic patient, you need to remove the potassium from the body.
Okay.
So it's definitely the choice. It can be given, but we know that it takes time for development of full action.
Fair enough. Now, the studies you have mentioned, Professor Mitaj, most of them, the potassium was more than 5, so that this drug is used to prevent hyperkalemia rather than to treat. I mean, yes, to prevent it,
yes,
mainly not to treat hyperkalemia. What do you think about this comment?
This was, the studies were conducted in the way to prevent or to normalize potassium if the potassium was higher than 5. But this, you would usually not consider the potassium of 5.5 in need of acute measures. You usually imply for hyperkalemia. You usually do something else that you do for acute, with the exception of diuretics. We never use insulin, for instance, in a patient that has potassium 5.5 or even 6.
Yeah. Dr. Mustafa, has potassium any role of palpitation immediately after meal?
Potassium use, you mean?
Yeah, no. Has the potassium level after meal has any role in palpitation? Some patients suffer from palpitation after their meal. Has the potassium level at any role in this feeling?
Yeah. Well, very clearly known that one of the symptoms of the patients with hyperkalemia is palpitation. And that's maybe by either of the absence of the P wave with the frequent PVCs, or with those sort of arrhythmias, which is more serious. However, if it is after the meal and the patient may have reasons for hyperkalemia, like being in heart failure and medication, probably it does.
There's one question here about Addisonian crisis. Does have anybody more any role in hyperkalemia caused by Addisonian crisis?
I could not comment on that. No, as far as I know, no data, but I didn't check for case reports specifically for that.
Yeah, but in general, Addison disease is a crisis, which can happen only on an acute phase, and subsequently it will be dealt with the replacement of steroid therapy and so on. Then it will be normalized. But if it is in a severe elevation of potassium, it might have consequences on the ECG, and it should be treated as a crisis, and it is one of the emergency situation you might need to treat.
Question here about the hypokalemia after treatment. Does it really lead to any major consequences like mortality if we get hypokalemia after treatment? I don't know what they meant by this question. I mean,
no,
what do you think?
they meant that probably the significant doses of this Baltimore could it reduce the potassium level to the significant hypokalemic level in order to have the changes of hypokalemia or no. As far as I know, briefly through the review of this, that this drug does not significantly goes to severe hypokalemia. Usually, it is just to bring it to the normokalemic phase. And Professor Vitaj might answer this question.
Okay, so hypokalemia was observed. It is rare. It was observed very rarely in the clinical trials, and that is the reason why I emphasize this importance of patient education. And as we do it, so the patients, for every change in RAASi therapy, they consult us. Because if you are giving Patiromer or any potassium binding agent to maintain potassium, and then you stop RAASi therapy, then you expose your patient to a higher risk of hypokalemia that can be dangerous. So the patients need to know that the drug should be used simultaneously with the RAASi inhibition.
We have many questions, actually. If you want to continue, we can. We have really more than 18, almost 1,900 attendees. Thank God for this meeting, almost 2,000. And we have more than 118 questions. Let me give you, Dr. Mustafa, this question about the ECG role. Since ECG has no really correlation to the hyperkalemia, then in which case the patient should be reported as hyperkalemic events?
Yeah, first of all, the hyperkalemia, you know that it is a laboratory testing, and then the laboratory testing will dictate how to treat. However, not every patient will have the same changes at the same level of potassium. Maybe somebody will have 5.5 and he might start manifesting the hyperkalemic evidences on the ECG, and someone might not manifest the ECG changes even with a potassium of 6. So the variability from person to person in responding to the depolarization effect of hyperkalemia is variable. And in that case, both of them has to be done. You have to check the potassium level and probably the ECG. ECG is an immediate thing to be done, and it gives you a lot of information during the acute phase, whatever it is. But the potassium level, you need 45 minutes to get the result. So I think the ECG can give you a clue, but it is not totally depending on the ECG. But you have to go for potassium level check.
There's one, yes, sir, please, Dr.
If I may add, so yes, exactly as you said, there can be a difference between the potassium level and the ECG. There are case reports of potassium up to 9 and no changes in ECG, and vice versa. Patients developed life-threatening arrhythmia with potassium of 6.5. So what we do in clinical practice, if the patient has potassium level of 6.5, the patient needs to be monitored, needs to be put on a monitor to see what is the heart rhythm. Because from 1 second to another, the patient can develop life-threatening arrhythmia even with potassium of 6.5. So I remember my highest potassium level in a patient of 10.6 with a sinus wave virtually, and we managed to do this patient without dialysis. The patient was not dialyzed, and the patient in 2 days had normal potassium level.
There's one question here about the cost effectiveness of this treatment. I saw some here, it's written that it might cost every week almost like 1,000 Saudi riyal or $268 for 1 week. So will it be practical in routine use, this medication? I don't know about the price here.
The price,
yeah.
The price is almost 1,000 almost riyal per month, not per week.
Per month.
Yeah.
So I think it's
almost,
yeah.
Which is, again, if we're going to talk about cost effectiveness, again, it's a drug that's given at home, and the patient would be monitored like once or twice a month. And if you calculate this compared to emergency visits and other modality of treatment, I think if you calculate it, it's more cost effective to have this medication.
For patients who undergo total colectomy, actually, Can we use this drug for it, Patiromer, or not?
This is a nice question. I don't know the exact answer. But
most probably
I
you
would
cannot.
say yes, because it needs to be sufficiently long in to bind potassium, long in your body.
But I think it's a no, because they need the pH of the colon, which is a.
Is the total colectomy was the question?
Yeah.
Okay, because so in the colon you have the big K channels that are mostly responsible for the exchange of potassium. So this is a tough question. I would not know the exact answer.
We have answered this question about how frequently potassium is monitored to start at start of Patiromer. How frequently you use it? You said after 72 hours, and then how after that? How frequently
at week
you use
one? At week one, and then you make a decision, clinical decision. I showed you the algorithm, which is, I believe, very, very useful. So 48 to 72 hours, then week one, and at week one you decide whether the potassium is lower than 8. Lower than 5. Then you maintain the starting dose. If it's higher, then you up titrate the dose.
Okay. I think we covered most of the question, and I think I have to thank you both, all of you actually, and thank our really sponsor before for Pharma for their help tonight. It was very, very informative session. I learned a lot myself. We have learned nearly about a new medication which raised the hope for the patients who had heart failure and chronic renal disease, and they cannot use the optimal treatment for their heart failure outcome to be better. Thank you, all of you, and I wish we'll see you more in such an interesting meeting. Again, we have more than almost 1,900 attendees. I'm very proud of the team who arranged this one, and for Dr. Fakhr and her team, and Dr. Mustafa, and our professor from Slovenia, Professor Mitai. Thank you very much.
Thank you very much for all of you. Thank you. We learn, all of us, in fact, from this session. Thank you.
Thank you very much for having you all. Thank you so much. See you soon.
Also from my side, thank you for having me in this virtual meeting, and hope to see you in person sometime in the future.
Thank you again. Thank you very much. All the best luck for you. Thank you for all this attended.